I'll start with a case. This is a 68-year-old man who fell from a moving train. And as you see, he has injury to the head of the femur. He has some comminuted fragments in the acetabular socket. He's got a hip that is dislocated, and he's got comminution over the wall as well. Not only that, he has also got injury to the pelvis on the contralateral side, type 3 crescent fracture, and he's got disruption of the symphysis and an anterior wall. This patient came to us on day 8. He was being prepared, experienced shortness of breath, and was diagnosed as a subacute, submaximal pulmonary embolism. So we diagnosed this patient as having an anterior with a posterior hemitransverse fracture with acute submaximal PE. So what are the decision-making factors here? So the first thing is basically the pathoanatomy of the injury. So he has a posterior dislocation of the hip, he has head impaction fracture, he has head comminution, he has AMDI, he has wall comminution, he has a contralateral pelvic injury, and he's got some physeal disruption. So do you fix or do you replace? So the questions we ask is, do you conserve, anticoagulate, do a delayed hip? Do you anticoagulate, do an IVC filter or fix? Do you anticoagulate, do an IVC filter or do an acute total hip? Do you anticoagulate, wait for a thrombus to resolve, do an IVC filter and do a delayed primary? So the basic questions that we are asking in these situations is when to remove the IVC filter, what is the duration of anticoag, choice of procedure, fix and replace, and the type of established shells we want to use, stem we want to use, the bearing couple we want to give the patient, and the rehabilitation protocol. So this patient went for an IVC filter placement and 3 weeks, underwent the procedure in 2 stages. So the first stage we fixed the SI joint disruption on the contralateral side, and then we went back in after a week to do a dual mobility with impaction bone grafting with fixation of the posterior column with plates and screws and a standard primary metaphyseal fixing stem. This is him at 13 months, walking well, fracture healed, the bone reformed, the bone stock reconstituted, and him very comfortable and doing activities of daily living. So the question that comes is that a lot of times the choice of what you do depends upon whether you're a trauma surgeon or whether you are an arthroplasty surgeon. But the question is that you have to decide which surgery is required, what is the least morbid surgical approach, and most importantly, what is the reconstructability of the hip. So we will talk about which hips you can reconstruct and do a fixation, and which hips need to go for an acute total hip. Adverse factors affecting the survivorship of your fixation, if you do choose to fix those hips, fix and replace in an acute setting, and fix and replace in a delayed setting, restoring the center of rotation of the hip and giving back the patient a well-balanced, stable hip. So the basic question boils down to the pathoanatomy and the pathomorphometry of what the damage is like and which is the second simplest surgery in terms of revision that you want to give your patient. So we'll not touch upon the issues that come with fixation. The issues which have to be addressed, which are the ones you go for an acute total hip. So severe intra-articular comminution, acetabular impaction in the weight-bearing dome, whether it is an anteromedial or a posterior-superior dome impaction, head impaction injuries, comminuted head fractures, pre-existing arthritic patients, abductor injuries and relative abductor dysfunctions, and elderly patients. These are generally those who would get chosen for a fix and replace strategy. The issues with delayed total hip arthroplasty, essentially what is the accurate assessment of defect size and type, accurate assessment of the available host bone, retained metallurgy with post-fixation total hip, hips needing total hip is a very important thing. Presence of ununited wall fragments, presence of column non-unions, and essential treatment philosophy essentially works around recreating bone stock, having grafts to restore bone, normalization of the offsets, using highly porous coated shells which can osteointegrate well, dual mobility cups if you have relative abductor dysfunction, and sometimes you need alternative strategies in severe acetabular defects like distraction fixation, cup cage constructs, column plates, and 3D flange cups. So post-traumatic situations can present as acute conversion to total hips, or delayed situations where the hip has undergone degenerative arthritis of the hip because of fixation failures or neglected disease. Now these essentially can present to a hip surgeon as having acetabular defects, or certain patients who have secondary acetabular dysplasia. And if you do the acetabular classification of Paprosky, you realize that a lot of times these hips are 2C, 3A and 3B, but they have an intact rim like the Paprosky doesn't have in these situations. They have intact columns, which will also be there in Paprosky classifications. The columns will be intact and supportive, distorted, but still supportive. And the teardrop lysis, which you will see in these kind of situations in Paprosky revision hips, are not seen in the post-acetabular fracture patients. So Paprosky classification and the AOS classifications that we normally use for acetabular defects after opening the hip are essentially, the hips that are not classification that you can use for post-acetabular fracture situations. So just walking through a few examples. A 2C acetabular defect, young 37-year-old lady did not get any treatment for this hip, presented at 4 years post the acetabular injury, and you have nothing on the medial wall, but you have a distorted rim and intact columns. So the essential thing is you classify the acetabular defects, plan on the acetabular side, think about offset management, bearing articulation, and plan for the femur side and the postoperative protocol. So you do the Ranawat assessment, and essentially you realize you have to distalize and lateralize this hip to put it back into its native center of rotation, and you have to do impaction bone grafting. And we did this hip, and this lady is now about 5 years post-op and doing fine. So post-acetabular fracture pelvic discontinuities, which is essentially a transverse fracture non-union, is something which we see fairly often with post-acetabular fracture complications. Another 28-year-old young patient, 11 months post-road traffic accident, did not get anything. So he's got an ischiopubic segment which is migrated inferiorly and rotated. So the basic thing is that does the patient have pelvic instability, what approach we use, exposure, and basic questions about what kind of fixation and rehabilitation protocols. So these were the choices that we were dealing with. The one decision that we took for this particular combined pelvic-acetabular injury with postoperative pelvic discontinuity was do a stage 1 fixation for the pelvis, because if you have an unstable SI joint and an unstable pubic symphysis, it is going to cause micromotion to the cup that you're going to place, and that basically will predispose to early loosening. So we did a distraction fixation for this, and we did impaction bone grafting, and this was the hip. This patient is now out almost 3.5 to 4 years. This is about 6 to 9 months old walking video. Another one, a vascular injury which occurred when we were doing a stopper on the table. 29-year-old male fell from a height. We were very gung-ho about being, fancy acetabular surgeons. Took this patient up on a stopper for a complex ABC 28 days post the injury. And we had fixed the false pelvis, and when we were dealing with the true pelvis component of the acetabular injury, this is where the iliac vein got torn. And it had to be repaired by a vascular colleague whom we had already sounded because it was a delayed injury. And we did a reconstruction of the false pelvis and left this hip waiting for about 5 months when he came back to us for total hip arthroplasty. So we did the standard reconstruction that we choose, and we had to plate. These are acute pelvic discontinuities. We plated the column, did an impaction bone grafting, and did a highly porous semiscoted cell with a primary stem. And this patient is done extremely well, and that's him at the 3-year post-op. Just finishing. So post-acetabular fractures can also present with secondary acetabular dysplasias, like this patient. Had an acetabular fracture, kept walking on it for about a year. Funnily and thankfully, when he presented to us, he had a very significant bone formation even on the medial wall. And as you see that we use this particular thing to our advantage. And when we took him up for surgery, we not only reconstructed the wall and the column non-unions with the bone graft, autogenous bone graft, but we were actually able to put a screw into the medial wall, which you will never normally put here. So we used this extra bone that had formed in trying to put in a kickstand screw to give additional stability to this highly porous coated cup, and this patient did well. And dual mobility cups are very, very useful in such situations. So I'll not walk through this case. This was another patient where we did a cup cage construct for intrapelvic cup. So the take home for acetabular fracture situations is that it's a diagnostic and surgical challenge. Solutions need to be individualized to basic geometry of the distorted pelvis. Solutions are complex and they need trauma and revision arthroplasty skills, and you need an effective team to do the job. What is important to understand is which hips go into acute total hip situations with an acute fix and replace philosophy, and the problems that you will need to overcome in delayed situations with or without hardware. Thank you for your time.